It's an honor to be presenting with this esteemed panel. I learned so much from these brilliant clinicians that we all have the privilege of working with and getting to talk to at the meeting. These are my disclosures. I think it's kind of been discussed earlier by Dr. Nelson about the various devices that we can utilize for the treatment of vascular skin lesions. And I think what rings true from Dr. Nelson's lecture is understand the device that you choose and know it well, and that will allow you to achieve the clinical endpoints that you want. And as he said, as per Dr. Anderson, be an endpointologist, because I'll go through some of the warning signs that you look for when treating vascular lesions, because that can, especially in the pediatric population, that can be very, for as safe as this technology can be, it's only as good as the operator doing the device. And so I specifically in my practice utilize the pulse dye yellow light shown at the wavelength and pulse durations here. Obviously, we've had a lot of great presentations on the value of the 532 nanometer specifically for telangiectasias and various vascular skin lesions. One of the novel applications that I wanted to touch on today was the role of the large spot size high energy pulse dye laser and a couple of studies published by Dr. Bernstein on the value of this technology for both rosacea as well as poikiloderma of Savate, your ability to use a larger spot size, higher energy, allowing for greater subsurface delivery of energy, and also allowing you more safe and effective treatment in patients with skin of color. And as Dr. Geronimus mentioned this earlier, we've published on the value of utilizing this technology, especially in newborns with port wine birthmarks, the ability to rapidly treat these conditions. And as I mentioned earlier, pick your vascular specific device, and these are the types of things that you can do and do very well with. And it can be a very rewarding and a very productive relationship with your pulse dye or vascular specific technology. The ability to treat all these conditions is just going nonstop in our office. I love this reference by Dr. Anderson in terms of knowing your therapeutic endpoints. In case of telangiectasias with the various devices shown here, your objective is vessel disappearance or transient vessel graying. I know Dr. Goldberg, speaking next, will get more into this in terms of knowing your endpoints for treating port wine birthmarks. It's obviously a little bit different in terms of, in those cases, you're looking for purpura. And then these are the same part of that paper that was published by Dr. Anderson's group in 2016 in JAD in terms of warning signs, warning endpoints. Metallic gray blanching, it means that you're having protein denaturization and you're going to end up with an adverse event, and that's shown here in figure 11. The figure in the middle is showing excessive cryogen cooling, and then you can see the Nikolsky sign on your far left as a result of inadequate cooling and bulk heating. I apologize. What I was given told me that I had 5 more minutes than they're currently giving me, so I'm going to, I suppose, speak faster. I'm going to have to skip some slides. But when treating rosacea, you're going to have to first manage it medically. You're going to want to control the inflammation. And we have a number of wonderful FDA-approved products. I use all these with the exception of brimonidine in our practice. And as you know, there's a compounding company now that allows you to compound several of these ingredients. And they're really nice products. They're really well tolerated. And for all of us who have rosacea patients, we know the sensitivity of these patients and their ability not necessarily to tolerate, obviously, products that are irritating. So I think these are very well tolerated in our hands. There's also a recently FDA-approved topical minoxidil, and there's, as you know, a new benzoyl peroxide that's been FDA-approved for rosacea. So I like to categorize these patients into telangiectasias with diffuse redness, and then combination of both. And I'm going to try to show this video, which will demonstrate that endpoint we were talking about earlier, where you can see. You're going to play. Can we play the video, please? You're going to see. Hopefully, you'll be seeing a visible blood vessel disappearance. And this was obtained with a 7mm spot, utilizing 13 joules per centimeter squared at 30 milliseconds. And you can see this excellent endpoint and the nice vasospasm of the telangiectasias. And this is the same patient immediately after pulse dye laser treatment. Obviously you're going to caution patients who present with telangiectasias in this region about the risk of recurrence and the ongoing role of maintenance. But we'll talk about topical oxymetazoline and the role that that's played in our practice to help minimize the chance of recurrence and the need and lengthening the duration between the required treatments. Diffuse redness, you want to counsel these patients that there's going to be more than likely a chance of recurrence, likely some keratosis pilaris overlap. With these patients, we're typically utilizing more shorter pulse durations, typically in some cases either transient purpura if the patient's willing to accept some purpura to achieve these types of results. And then telangiectasias with diffuse redness, this is where that is the large spot technology, high fluence, novel pulse dye technology I mentioned earlier has really shined in our practice. This is 9 months after one treatment. You can see nice improvement of both the telangiectasias and underlying erythema. You're going to be utilizing longer pulse durations for those larger telangiectasias and then shorter pulse durations in a larger spot to treat the background erythema. We do that on the same day, and we have the patients use cooling between passes. I'm having a little bit of trouble with the mouse. If y'all could please help me advance the slide, it'd be great. Sometimes okay. I was just going to say sometimes patients will request treatment of the eyelid telangiectasias. Obviously, you want to insert a metal ocular shield. Another patient with the combination of telangiectasias and rosacea with nice improvement after 2 treatments. Next slide, please. 9 weeks after 1 treatment session. Next slide. And then, again, because of time, I'm going to have to run through this, but basically we've published both a retrospective and prospective study in LSM looking at the role of topical oxymetazoline with 595 nanometer pulse dye laser, getting this synergistic effect to target telangiectasias and some of the underlying blood vessels and the smooth muscles with oxymetazoline to help, again, reduce the risk of recurrence and maintain the results. And this is something that will apply right after treatment. And we'll stop it, the oxymetazoline, next slide please, 2 to 3 days prior to treatment. So this is a slide that was published in the study, just again showing our most commonly utilized settings. Again, typically the longer pulse durations, 7 millimeter spot for the telangiectasias, followed by the 10 to 12, even 15 millimeter with the large spot with shorter 3 milliseconds for targeting the background redness. Next slide, please. And this is a paper from that study we published with Dr. Munavali, 4 weeks after 4 treatments utilizing this combination approach. Typically, we'll do the oxymetazoline for 4 weeks prior to initiating treatment. That's what we did in these studies. Next slide, please. 1 month after 3 treatment sessions. Next slide. And again, mechanism of action here, targeting the vasculature at different depths, helping reduce the chance of flow recurrence post-treatment, enhancing the probability of vessel shutdown, ultimately allowing to optimize your results. Next slide, please. Next slide. And then this is the prospective study I mentioned. Next slide. Next slide, please. Here, 9 months after 5 treatment sessions, pulse dye laser and daily oxymetazoline cream. Next slide. And next slide, please. And so we'll commonly go down down to the neck and the chest area. Next slide. With these lasers, they work very well. Again, we're typically utilizing larger spots, typically 12 to 15 millimeters. Shorter pulse durations, you want some either flash purpura so typically we're utilizing about the 3 millisecond range. I know Dr. Geronimo sometimes utilizes the 1.5 millisecond range. This is something that we presented at last year's meeting. This is the role of global cryomodulation. That's a term that was defined by Rox Anderson for this targeted cooling probe that we'll show here in the next video. And we had the idea of combining it along with my colleague Dr. Murray, with various energy-based devices. And I think the cutting edge session this morning pretty much described it perfectly, with the goal of doing post-treatment cooling, extracting some of that heat. And in our clinical practice, we're finding that, next slide please, we're finding that it helps with recovery, reducing, this specific patient was treated with a fractional resurfacing device. And here she is undergoing this 10-minute cooling treatment where you're in a very controlled and algorithmic way extracting heat and cooling the skin. Next slide. And this is a paper we published at ASDS, where you can see we did a control side versus with pulse dye laser only versus pulse dye laser and cryomodulation, which is the left side. Slide B is immediately after treatment, and then slide C is 2 days after. You can see reduced erythema and edema. Next slide. I'll just wrap up with rhinophyma because there's something new we're doing on that. Next slide. This is our traditional CO2 laser results, and sometimes we'll combine it with ablative fractional resurfacing to help shape the contour. Next slide. Next slide. You can see this patient had involvement of the forehead as well with nice improvement. Next slide. And then something that we're presenting here, and then I'll wrap up, is a novel ablative 2910 fiber laser for nasal contouring with my colleague, with my fellow Dr. Swally. Next slide. And then if I can just quickly show, so that we have the ability with this technology, can we play both videos, please? To deliver a 4 millimeter, 1.5 diameter, let me see if we can play, for debulking the lesions. And I think what's most revolutionary about this technology is that it hurts less because the way the pulse structures, the way the technology is engineered, the smaller spot. And then can we play the other one? And then the recovery time as well, and I'll show you some examples of that. So that's, and this will be presented on Sunday. Can we play this one? And you can see that 100 micron depth that we're using to contour the nose. Next slide, please. So thank you, everyone. I think, we've come up. Next slide, please. These are just some before and afters. You can see post-op day 3. Next slide. Post-op day 15 and 22 with excellent results. Nice recovery. Next slide. And obviously, when you're treating with erbium laser, you're lessening. Next slide, please. You're lessening the risk of hypopigmentation. And Roy Geronimus published a paper that about 18% of patients treated with CO2 can develop hypopigmentation. We don't see that with the erbium wavelength. So another advantage of that technology, in addition to the less intraoperative pain and downtime as compared to CO2. Thank you so much.